would like to talk about the work on this work group on redefining and reconceptualizing addictions or substance use disorders for the new classification. And again, the presentation has been prepared by Dr. Auriacombe. And how do I move slides?
No, not that one.
Oh, this one. Okay.
Yeah, this is
just
laser.
Okay.
Yeah.
Wonderful. So again, there were several people that took part in this effort. Many of them were clinicians. Some were epidemiologists, and we also have a very strong input from statisticians. So again, representing the wide range of experts working on this group of disorders, which I thought really contributed to very kind of in-depth rethinking about these issues. In order to have some kind of research basis for the changes, they pulled together a lot of studies that were both from US as well as from other parts of the world, in adults as well as in adolescents, in various settings. Altogether, more than almost 30 studies and 200,000 participants that were evaluated to learn about the nature of these disorders and how we can maybe better think about grouping them or describing them. So just in summary, as we have discussed, there were three major changes. The first one was that we eliminated the separation between abuse and dependence, and we've replaced it with one substance use disorder for each of the classes of chemicals. The second change was that we've added the non-substance behavioral disorders, so we no longer can call them substance use disorder. We decided to call them addictions, and I will get back to this, the fate of this word. But we've added non-substance addictions such as gambling disorder in the section 2, and then internet gaming in the section 3. And the major development was the addition of the craving as a symptom associated with this class of problems, and we'll talk about this. So actually, we start with that, and this is the research done by the Bordeaux group that Dr. Auriacombe defined, in that they looked at patients who were in treatment stable, and they did assessments. They did both behavioral assessments, so how strongly they respond to cues, both non-drug cues and drug cues, and they measured the intensity of response. So again, you can have no response to cues, or you can have a high response of the cues. And what they found out, this is a prospective study, is that people who month to 3 months later would relapse, those people had much stronger response, which was craving response to cues, as opposed to people who were controlled. So clearly you have now behavioral marker of a disease course, which is, I think, quite exceptional in psychiatry. And the same happened for a hormonal marker, which was cortisol. Again, people who would end up relapsing a few months later had a higher cortisol level after the challenge. So again, there is a biological basis now for the classifying disorder and the course of the disorder, which made it a very important criteria. So the problem that we're seeing before was, again, that many people were confused about the abuse dependence. Are they related? Is this just the prodrome of the dependence? Are they independent? And there was really difficulty, especially that the dependence name was confused with the physical dependence, who was one of the core symptoms. I think there was a lot of confusion about that, which called for some kind of rethinking of this approach. In addition, we had a hierarchy. If you diagnose someone with a dependence, you could no longer diagnose abuse, because dependence was considered to be a more important disease that will encompass everything else that's happening with a patient. But that way, when you diagnose this hierarchically, there was really no point of diagnosing abuse anymore. It had a very poor reliability. So again, it's something that had to be a better way of dealing with that. And the finally problem was that it was very easy to diagnose abuse. Again, you only had to have one symptom in the past 12 months, And often the symptom was that you got arrested for either driving while drunk one time or for possessing low doses of marijuana. Clearly, it was not meant to be kind of that way to diagnose a disorder based on this. Nevertheless, it was happening. So again, was there a better way to deal with that? And finally, as Dr. Regier mentioned earlier, is there were these patients who clearly have problems. They were clearly impaired, but they only met 2 symptoms on the dependence, and you needed to have 3 to have a diagnosis. So again, they had the problems, but they couldn't be diagnosed, couldn't receive treatment or reimbursement, and left them untreated. So the way to deal with this concept, the group employed this very sophisticated statistical method called item response theory, which is just like a fancy factor analysis, which basically pulls data from the large group of patients and see how they group. You know, do they group together? Do they group separate? Does this tell us something about underlying problem? And the result of this analysis was that they did not really separate into 2 disorders. You know, when you look at hundreds of thousands of patients, you know, all those symptoms group together as if this was one underlying entity rather than 2 separate entities. Again, if we want to move towards thinking more about etiology, you know, that's clearly something we have to think about it. So there is a nice way to look at that, and I'll just show you example from different disorders. You can plot this on this plot. You have a severity on the right, so lines that were more to the right reflect greater severity, and the slope represents how well they discriminate presence or absence. So what is considered to be the line that is very steep is a very good symptom, which nicely separates pathology from lack of pathology. But here you can also see whether those symptoms kind of group together or not. So the red line represents criteria for abuse, and the black represents DSM-4 criteria for dependence. And again, if this were 2 separate disorders, you would think that they will kind of go together. However, you know, they're all over the place. And the one that has the least of the slope, so the one that is like the poorest kind of serving for diagnosis, seems to be the legal problems. And the same happens when you look at cocaine abuse. Again, the legal problems is most to the right and not very steep, and everything else is, all the other symptoms group in the middle without separated grouping dependence or abuse. And finally, alcohol dependence, again, the one most to the right is the legal problems. If you were to plot craving into this, craving would be somewhere in the middle. So again, the new symptom very well fits with all the other symptoms. So it sounded that it belongs much better into this, this underlying category than the legal problems, and that was one of the reasons to justify that these are not 2 separate entities, but rather one. One entity that has clearly various levels of severity, and that's another dimension that has been such a strong presence in DSM-5, which is the dimension of the severity. Again, like with most of the disorders, there is no threshold. We know that there is just a continuum, and at some point, purely arbitrary, we decide to call the entity a disease, or disorder rather. We don't have many diseases. So you have to make an arbitrary decision how many items is enough to make a diagnosis. And here, the main really reason why we make 2 and not 3 was to make it consistent with the DSM-4. So we didn't want suddenly to have twice as many alcoholics in the US because of the changes in the diagnosis, right? That would be very confusing to people. So the analysis was done to determine, actually there were epidemiological studies when people were diagnosed according to DSM-4 and diagnosed according to DSM-5, and you then had a chance to look at the threshold that will be most similar to DSM-4. So studies, for example, done in alcohol drinkers in the US, which is about 65% of the society, when in the DSM-4, we had about 11% of people meeting criteria of combined abuse and dependence. With DSM-5, when you have 2 symptoms only to have a diagnosis, you had, I think, 10%. But if you were to increase to 3 symptoms, suddenly you have only 6% of the alcoholics, right, in the country. So clearly, it and I think similar, although less data was done for other diseases, and luckily it was pretty consistent, that 2 and more sounded like a nice cutoff for this differentiation. And here it is, and it was decided that you have to meet 2 criteria to have a diagnosis. So this is just one of the examples how employing research methods and using available evidence from the large epidemiological studies helped us to redefine diagnosis. And the decision was, again, to combine abuse and dependence, to add the craving, which seems to be better than the legal problems, which was removed. And it also allowed people to now have nicotine dependence to be more like other substance use disorders. Before, we did not have nicotine abuse, we only had nicotine dependence. And it looks like the nicotine use disorder is very similar to nicotine dependence, so that didn't really change much. But clearly, those are people that can benefit from the treatment, which is like treatment for any other of addictions, right? We have a combination of behavioral therapy and the medication, and it's very effective. So clearly, nicotine belongs here. We've also now collected for the past 20 years, and we've actually both experimentally were able to show, as well as epidemiologically observed, the emergence of cannabis withdrawal, which was questioned by many people, is still questioned by people who are, have other agendas to change how the substance is scheduled. Nevertheless, it's very clear withdrawal syndrome, not that dissimilar from nicotine withdrawal, has its unique characteristics, and now it's listed and can be given as a psychiatric diagnosis. Caffeine withdrawal was also added to that. I think it was before as in the section for further studies, and now it got moved to Schedule 2, Section 2. And the diagnostic threshold was set at 2 criteria, and the severity was indicated by counting the number of symptoms. And we have, I don't think we have a number of symptoms, but as we were discussing, 2 to 3 symptoms is categorized as mild, 4 to 5 as moderate, and 6 or more as severe. And it can be now it's gonna be very important part of the diagnosis. Before, it was very difficult because people who had 3 symptoms only and people who had 7 had the same diagnosis, but they clearly are very different clinical entities. So how does this new diagnostic criteria compares with DSM-4? Again, generally there is a pretty good agreement, and Wilson Compton did a study comparing that, again, looking at epidemiological samples. It's pretty much, we did not dramatically change the prevalence of the psychiatric disorders. And again, the agreement is maybe higher for different substances depending on how many symptoms you have, but that's kind of changing. This is just to show that when you actually add DSM-5 on top of DSM-4, the percent of patients, I think, diagnosed doesn't really change dramatically. So the prevalence stays the same with the new category. So that's what we want to have. This is the classic paper that describes all the work that went, or summarizes all the work that went into this changing the definitions. It's been published last year in the Green Journal. So pathological gambling, it was, again, as a category for future study in DSM-4. It's been studied extensively since that time, which led us to rethinking. First of all, it's no longer in the category of impulse control disorders because it looks much more like other addictions, behavioral addictions, than like intermittent explosive disorders or other disorders, although it's often comorbid with the impulse control disorders, but it's much more comorbid with substance use disorder and it looks much more like any other substance use, both in comorbidity, family history, physiology. So there are very similar brain, for example, alteration that we can show in response to triggers in both chemical abusers as well as people who are behaviorally dependent. And also treatment is very similar. We use a behavioral method, the cognitive behavioral, relapse prevention, community reinforcement. Many behavioral methods very well are helpful for both of those disorders. So, and again, the prevalence, many people with pathological gambling have high levels of alcohol use disorders, and again, vice versa. They basically occur very often together. So the recommendation was to move the pathological gambling from impulse control disorders into the substance use disorders, and change it from pathological gambling, which was thought to be very kind of pejorative, and it's basically also duplicates gambling. It's like, by definition, it's not a regular, recreational, whatever, gambling. I don't know. But it was thought to be kind of redundant and not very useful, and it was changed to gambling disorder and put together with substance use disorder. But then the issue came, it's not a substance, right? So how do you then name the class of the disorders when most of them are chemical, but one is not a chemical? And there the name of addiction came back because there was no better name. The addiction, they were going back and forth for years to try to, some people were strong proponents that addiction is what our field is about, and it's a well-accepted term, it well describes, everybody knows what it is. So it should be, that's how the class of the disorders should be named. Other people felt that it's pejorative or has all the other baggage and did not like to have it. So the recommendation was to remove it, but I think the board was it that brought it back. I don't know, who was it that brought it back to the title of
the chair of the committee brought it back.
Okay, who was the main proponent of this to start with?
It's interesting, there was a real split between the alcohol research community and the drug abuse research community. And the alcohol research community was very averse to the addition of the term addiction. And the drug abuse community thought, this is the only way to go. So it was an interesting dynamic, but the board of the APA agreed. There's an American addiction psychiatry group. There's addiction medicine. We're addicted to oil. I mean, it's a common term, but the dynamics around the use of the term were really quite astonishing for those of us who aren't in the field. But it really was an internecine addiction psychiatry debate that ended up with addiction in the title.
Again, as in other fields of psychiatry, there is very strong beliefs and convictions in our field, and we're very, very strongly want to defend, one way of understanding or treating disorders against the other one. Because again, science is not the only thing that affects, as you know, how people who use substances are treated in society, also treated as patients by our colleagues. There is many other notions that people have about using substances, and that place comes into play. And again, the threshold was further reduced to be more consistent, I think, with the other substance use and addictive disorders. And again, so threshold was lower. This is some reasoning for that. Again, to make more parallel, craving certainly is a part of gambling. People do describe very intense urges and cravings to engage in the behavior, which is not that dissimilar from other addictions. This is mean intensity of cravings for people who are drinkers or even opiate users. You would think that opiate users will have much higher levels of craving, but on average, it looks like all of those have pretty similar, which again underlies the importance of this. And internet gaming, again, it's a new entity that clearly emerges, and we have to somehow classify it. It varies in different parts of the world. Clearly, undeveloped countries don't have such access to internet, yet highly developed countries like Far East Asia have their internet basically present in every aspect of their life, and clearly some people will develop issues. So again, those are the large number of patients that describe to have severe impairment because of the inability to disconnect themselves from gaming and re-engaging with the world. And those patients, the prognosis is poor. People can end up severely, not only socially isolated or occupationally impaired, but also even medically ill. So clearly this is a problem. We need to somehow classify it. But again, it was felt that this is still early on. We don't know really that much about it. We don't know much about neurobiology of this, comorbidities. Seems to be a little bit different than other addictions. So I think it was left in section 3 for further study. And this is the paper that some of our colleagues have well, this is actually pathological gambling. So this is not the internet gaming. But what about associations? Right, I mean, again, all of those disorders, as you know, are highly co-carrying, maybe 50, maybe even 70%, definitely people presenting for treatment. Most of those people who have another psychiatric disorder, right? People come to treatment not because they are enjoying the cannabis, right? They come to treatment because they develop depression, anxiety, medical problems. So clearly, by definition, in the clinical setting, this disorder, which is co-occurring with other psychiatric disorders, and also there's a lot of comorbidity between each of the substance use, different use disorders. So again, you remember that we have not only the use disorder, but we also have intoxication and withdrawal. We have various ways to describe what's happening with the patients who use substances, who have substance-induced psychiatric symptoms. Substance use complicates the course of psychiatric problems. Clearly, if you don't pay attention to substances, you're missing a lot when you are doing your job as a psychiatry. Yet addiction is not something still different in different societies, that people don't necessarily think that this is important. People clearly don't spontaneously disclose this is a problem unless it becomes a problem. So it's still difficult, and you can miss a lot treating patients if you don't assess the extent of substance use and how it interacts with the psychiatric problems. And I think dsm5 is trying to do a good job of bringing it more, giving it greater importance. And the last thing that, unfortunately, we talked about it right before, that had to was decided not to be excluded, was the polysubstance abuse disorder, which was, again, you met the criteria if you could have one of the symptoms from different substances. So you can have a tolerance to one substance, then you could have inability to cut use to the other substance, and then in decrease in other activities due to the third substance. And so that helped people who only have 2 criteria earn the diagnosis. And clearly there are many patients who use a variety of substances, and they may have people use cannabis and claim they don't have any problems with cannabis, but when they start abusing heroin or cocaine, they become having problems. It was clearly a useful way to giving someone diagnosis and helping them to receive treatment who might have had a threshold. But it was decided that it was very difficult to do studies with these disorders, that again, every polysubstance disorder is different. So how can it be one disorder if they're so different? And right now the emphasis was on diagnosing each specific substance, whether you have use disorder or not, and then developing a treatment plan that will target all of these substances as a solution to this polyaddictions. Yeah. So again, there might have been disagreement with some clinicians about removing this diagnosis. And right now we have them all kind of independently diagnosed. And you can always say that it's a sub-threshold or otherwise specified when you don't have a full criteria, but you still want to make it a focus of a clinical work. So this is just a summary, so we've already went through that. I'm not going to repeat it, but there were some other changes made in, for example, substance-induced psychiatric disorders. It was very confusing in the DSM-4R in terms of you had to separate that something is more severe that would be expected in the course of substance abuse to earn the diagnosis. Again, it was very difficult. Right now, it is independent. You still try to kind of diagnose independent domain, give them diagnosis, and you develop treatment plan rather than try to connect them. I'm not sure that's correct, but I think trying to connect them that one disorder will precipitate the other. So we no longer have a primary versus secondary, but we have just separate disorders. If you meet criteria for the disorder, you get a diagnosis. So that was one other change. I'm wondering if you have any questions. I think that's it, but I'll be happy and Dr. Rogers.
I wonder where dsm5 recognize some behavioral addiction like nymphomania, for example?
Right. I don't think that nymphomania. I'm not sure. I mean, I think the DSM did away with that term quite some time ago. But again, you have the same set of behavioral problems may belong both to paraphilia, to addiction, and clearly there is a lot of, and it's very individual, and there is a lot of overlap. But
there was a lot of discussion about the possibility of including kind of a sexual addiction, and particularly after some celebrities like Tiger Woods and so forth were identified as having some major problems in this area. And there are lots of treatment centers for sexual addiction, in the U.S. And people will check into these centers when they're caught, or some require some, have some social consequences of this. And many of the treatments are very similar in terms of 12-step programs and the like that people go through with these. There was a concern that the Board of Trustees had in the APA that there was not an adequate research base. The recommendation of the task force was that or actually the committee was that there be a hypersexual disorder, not that they link it to an addiction per se at this point in time. But that was not accepted by the Board of Trustees. The task force was willing to put out criteria, and there is a set of criteria that are now established that have been published on hypersexual disorder that hopefully people will do some research on. But that's the status of that behavioral addiction. And as I had mentioned, that there were other areas that were of concern. Shopping addiction was another one, as well as the sexual addiction were two, and internet were kind of the three major behavioral addiction that were of concern, and the decision was only to put the one form of internet use into Section 3. But the format for doing this, I think, will develop, and as I said, there are lots of clinicians out there who are treating various forms of sexual, hypersexual behavior.
Is impulse control rather than addiction, I think?
Pardon?
Right. Shoplifting and like that.
Yeah, shoplifting and hypersexuality, it is impulse control rather than addiction, isn't it?
Well, that's the question. The question is whether or not, what's the definition of an addiction? And I think what has started to emerge is if there is this strong craving criteria as opposed to impulse control, and how you separate, impulse control issue from craving. It was decided that gambling was not an impulse control disorder. It was primarily, it was most similar in terms of some of the imaging studies of that show the same reward systems in play as is true in substance use. And that's the reason it started to go more into that direction.
Let me say, craving is related to withdrawal symptoms.
Some-
Withdrawal symptoms. Withdrawal.
Withdrawal. Sometimes it is, but often it's not. So, you know, yeah, you're right. Many people who are in withdrawal would have craving, but clearly many people not in withdrawal will have craving. There is a lot of, again, these cross-cutting domains that play a role in these disorders, and there is a lot of overlap, and hopefully at some point we'll have a better way of grouping them, but, you know, I think.
Thank you very much. I have just two questions. We'll start with the first one. If we remember the definition of addiction, for example, by ASAM, American Society of Addiction Medicine, it is clearly indicated regarding the dysfunction. And within the definition of addiction, the dysfunction of the memory circuits in the brain, in addition to the reward system, etc., etc. On diagnosis and on diagnostic criteria, on review of the diagnostic and making this 11 criteria, why we are not seeing memory problems or memory dysfunction within the criteria, although actually we are seeing it in the clinical setting. So, does it have any implication on the diagnosis or not yet? Because if you will see the reward on the for example the loss of control and craving with etc. You will find that within the definition some of the criteria expressing this dysfunction, but memory issue, and we know that addicts have memory problems regarding it is part of their problem.
Right. The way I look at it is clearly the memory circuits in the brain are involved because addiction is a learning, right? It's a learned behavioral response. So you need to, you know, to change how you respond to stimulus, and you need to have intact memory system. And that definitely that persists for life. You know, this is a type of memory that you don't really forget, you know. And this memory then triggers the other symptoms. I think that the criteria are more on the symptomatic, superficial, the clinical kind of relevance, so the things you can easily detect. Now, the memory in addiction, there are two types of course, there's this, you can call pathological memory because they have this response to the cues that they've previously associated with drugs, right? They have this hyper arousal, as if I remember it, you know, small things will remind them.
And the other issue regarding the memory, they are omitting at least or covering memory of the bad events when they are
absolutely.
This is in relapse. This is very important.
Absolutely.
Issue.
And
yes.
the other part of the addiction is that there is this denial or kind of selective, almost like anosognosia, selective lack of recall of the negative consequences or even what's happening right now. They have no ability to connect that part of their behavior is pretty problematic and it run them into trouble, and again don't remember. So there is certainly a way to describe what's happening with them as a problem with memory. There's other ways of describing. You know, another just aspect I want to bring it up is that chronic drug use clearly may lead to cognitive problems, including memory problems, and they cannot access treatment or benefit from treatment because they cannot focus, pay attention, have an intact cognitive functioning. And actually pro-cognitive strategies, both behavioral as well as the pharmacological, is certainly one maybe novel way of thinking about treating addiction. If you make their memory better, their thinking, concentration, they can take advantage of treatment, or they can just maybe make better decisions. And certainly there is a nice area of research. So clearly maybe that will be in the future edition, there will be more research support to talk about these aspects as a core feature of addiction. Right now we just focus on a very superficial, right? Inability to control the behavior and gradual replacement of all your other pleasurable activities with the drug-related activities, and then the physical dependence. It's very kind of simple right now definition. I think, but clearly addiction is very complex behavior, and it interacts with the social, interpersonal, economic, you know, and many other aspects of our medical, of our lives. So it's much more complex. But I think for the purpose of the definition, we have to keep it very That's my way of thinking of that. But hopefully memory will be, you know, because we do see dysfunctions, absolutely. So we have a marker. We could probably, I could look at the image and can say that this person is very good probability that they are in a kind of arousal that has to do with exposure and to the substances.
I will give just an example. It is very common in dealing with addicts for them for sort of two defense mechanisms, the denial or minimization. So it can be just one of the criteria, for example, that one of the features, and it is very common we are seeing with the addicts, that they are trying to deny the problem, and part of it, they are not faking or lying. Actually, some of it, part of it, it is a memory problem, or minimizing, and we are not seeing it in the criteria that
clearly
it's
in
common.
Some ways of treating, this is the core of the addiction. Like AA in the United States, the denial is the most important. They don't care about everything else. But the denial seems to be at the core of the disease. And it is true that it's something unusual. It's not the normal functioning of the memory systems.
My second question, topic of cannabis-induced mood disorder was an experimental in DSM-4, I think, and continues to see, I think it is still in the section 3 in DSM-5, cannabis-induced mood disorder. Still, it is not put again in the, so it is still in the experimental.
No, it would be section 2.
I think it's still in section 3.
Any substance-induced mood disorder would be a section 2 diagnosis, whether it's cannabis or caffeine. You know, I think there is an ability to diagnose that in section 2. You know, I think there, the question is, there is a cannabis withdrawal. There was the cannabis.
It is included now.
Right.
Yes. But I specifically because I looked for it in DSM-5 in the substance use chapter about cannabis-induced mood disorder.
I don't know if that specific drug is identified as an induced disorder. That I don't know. I'd have to look back myself.
But certainly it happens, you know, because we see it in cannabis as much as in stimulants that people come with a mood disorder.
It is actually maybe our problem. We are not doing enough research or whatever. But in the real life, we are seeing, especially that, as I mentioned here, maybe the second most common substance abuse in Saudi Arabia is cannabis. So we are seeing many cases which having mood disorder.
I think when people come for treatment, they mostly come to treatment because of the depression. And even if they come to treatment because they can no longer function, you know, because of the substances, they don't progress in life, they cannot achieve anything, there is a presence of the depressive symptoms. So in clinical population, absolutely, I would think that those will be, you know, very prevalent. In the epidemiological samples, I think it will be less of an issue. But it's a good point. And then the question obviously comes to cannabis-induced psychotic kind of pervasive.
It's very clear and is mentioned, actually.
Right, but it's like, you know, we would like to get experience from other countries. You guys may have a more experience or different way people use hashish or different constituents. What's your sense as far as cannabis use early on in life precipitating onset of schizophrenia type of disorder, because we know there's not one schizophrenia, whether you see it, how often, and you know, what's the best way to kind of, you know, deal with it. Yeah. To Marty.
Let me ask you, for a long time we are asking, addiction, is it an illness or misbehavior?
Right.
Good, you are here.
Right. I mean, clearly those are questions that don't have an easy answer, and I think no one, thinks anymore that there is an easy answer. You can look at it from many different sides, and a lot of the ways people look at it are influenced by the cultural norms, right? Is it a criminal behavior? Is it a moral behavior? Is it the purely medical problem? And I think there are various ways of looking.
It's a medical
at this.
condition and it needs a treatment. Like, is there any place for punishment, from your opinion?
Again, there are many levels, right? But clearly we are, the way I can start talking about this is a long discussion, whether aversive treatment, whether punishing someone would change the behavior like that, and there were formal treatments developed. Parts of the world kind of embrace this treatment. Certainly Russia and other, I think, Far East countries did embrace this as a kind of legitimate, because it makes sense. Like, if you would punish them behavior, you're hoping that people would kind of extinguish or stop doing that. And you can suppress it, absolutely. I'm sure you can suppress the behavior if you punish enough. You can suppress paraphilias, you can suppress many other pretty serious kind of intractable conditions. But is that a permanent solution? Is that gonna change someone, help them, kind of, recover from that? That I would probably say no. There are better treatments that are, I think, better suited to promote kind of recovery. But then there is this human rights issues, of course, right? That coercive treatments are not consistent with the UN standards of the treatment, and it's been clearly stated that any forced treatments for substance abuse is unethical and it's not supported by UN. So then you have the international norms that clearly do not support that people should seek treatment and receive treatment at free will. But sure, if you lock people up, they're not gonna use substances. But I'm not sure if that's gonna. We know that after they leave the controlled environment, they're gonna continue to use substances. That is very difficult for them to, for people who are truly affected and addicted. Now, for people who are using substances and selling them, that's a different story, right? Drug dealers who may be also recreational users, you have a different story. But for people who truly have this, memory problems, this abnormal behaviors, abnormal brain response, family history, clearly, hopefully we have better ways of helping those people than.
Distribution and smuggling or trafficking is an integral part of the problem, because usually they take their share if they do these things.
Absolutely, many people, but the most successful, my understanding.
In the core of it.
My understanding, working with many low-levels drug dealers, patients, that people at the top are not really. Most of them are not addicted. They are very, skilled criminals. But people in the middle, a lot of people, of course, support their substance use by selling. But again, I think we can make better. We can do better by treating their behavioral disorder rather than thinking that if you lock them up, this is a solution. That's just my.
Are there any other questions about other areas that you'd like to focus on before we finish up today?
Doctors in the back, any questions? No?
Yes, please.
We have doctors in the front only, dominating the discussion, which was great.
Actually, the question is for both of you. I know homosexuality was abandoned from the psychiatric disorder since 1970s, from DSM, homosexuality.
Right.
And
homosexuality.
Homosexuality. Till now, regardless of the cultural differences and religious differences between the globe, till now we are seeing some of the people who are having homosexual tendencies, and it is ecodystonic, they are suffering from it. They want to get rid of it, and they are suffering, and they did not want the answer that this is something human behavior or whatever, and this is normal, this is accepted. Maybe this is accepted in some communities, it is not accepted in other communities. Regardless of this, even if the person has the choice to go to another community where this is accepted, but if he by himself considered himself as abnormal, and he wants to, he is suffering from it, and he wants to be treated from this thing. So do you think that this is still a gap in the psychiatric classification usually about this issue? Yeah, does those people have the right to be treated? Because, for example, if you want to look for any treatment or change, you will not find after, and it is in the medical literature difficult to be found, and you will not find, and I don't know whether if anything it will be published or not. This issue for the people who are suffering, and they, by their own choices, they want to change, and they feel that this is not the thing which they want, regarding talking about the human rights, etc. So what will be the behavior as a psychiatrist when we are facing this issue?
Well, I think the first issue of a physician is do no harm. And the question is there an evidence-based treatment that would lead you to think that by working with these people, you can actually fulfill their desire to reduce this, internal goal that they have to change their sexual orientation. Certainly, we don't have any evidence that sexual orientation change treatments are effective. And so I think, there are even some states in the U.S. who are trying to make it illegal to offer such treatment. Frankly, we don't believe it's a good idea for states to enact that kind of legislation and get involved in, a professional decision about, what's an acceptable or, treatment or not. So we would be opposed to that. On the other hand, we don't think that there is evidence that that there's any dependable treatment intervention that is going to help these people be successful in changing their orientation. So that's our approach. We don't think that it is a disorder, a mental disorder. It doesn't meet the usual criteria for mental disorder in terms of really impaired function. The only thing that it did early on, there was distress. But it wasn't clear if this was distress because the social pressures that were on them or internally generated distress. And I think there are clearly some societies where having a homosexual sexual orientation is extremely distressing to the families, to the individual, and some situations where it's downright dangerous to express an interest in retaining that orientation. But from a medical standpoint, we don't think it would be good to say that the medical profession should be involved with trying to achieve this kind of a change. So that would be our approach. Whether it's a treatment gap, well, it's not a medical treatment gap. It may be a social service issue. It may be some people say it's a religious issue, but I think for psychiatry, we've defined it as not within our purview. And people who have tried to do it have tried all kinds of aversive treatments and the like to unsuccessfully, and have caused great harm to individuals in doing it. So as a result of that, we try to do no harm and to avoid getting involved with that form of treatment.
And what I would just add is that we can still be helpful to those patients. They can still benefit from the supportive psychotherapy. They can still have a safe space to explore the kind of struggles and conflicts. Usually it's good to find a psychiatrist to work with them that would be neutral, does not have his own biases against the diseases. Sometimes having, in US, it's very popular that you would refer to someone who psychiatrist who specializes, is either gay themselves or may specialize working with these patients, and I think patients can find a lot of relief, by still being, being able to talk about their struggles. And I think that we can certainly help, but I certainly agree with Dr. Regier said about this being outside of the purview. At least that's the conclusion we came to as an American psychiatry.
Why not classify it as non-substance addiction? they are craving, but they are not happy.
But again,
like that, but they cannot.
Right.
I don't think it has the characteristics of addiction. It doesn't have, certainly. Well, I mean, I think this is an area where there are obviously strong personal agendas and social agendas, societal agendas, political agendas, and so it's rife with all kinds of difficulties that we decided how to deal with it back 1972, I think, and it took the WHO a little bit more time to remove homosexuality from the International Classification of Diseases. So but it resulted early on of actually limiting immigration, and it was really a very
un-American,
negative,
un-American at least, and
right.
and kind of the values that our society supports. It was
right.
that.
May I have the last question? Sure. May I?
Yes.
You are authentic in classification system. Okay. You are authentic in classification system, right? Doing your work, are you exposed to any political pressures?
Are we under any political pressure?
Yeah. Yes or no?
I would say we're.
Excuse me.
It depends on how you define political. I mean, within the field of psychiatry, there are a lot of political pressures. Because psychiatry has its own politics, and certainly we had to deal with those. We didn't get involved with what I would say. Well, let me step back a bit. We had calls from congressmen who were concerned that some of their constituents were lobbying them to change, for example, learning disorders. They wanted to have a special disorder just for dyslexia, for reading disorders, because there's a whole society that's built up. And they decided that they would go to their congressman and try to get the Congress to impose on the DSM process, this particular approach, whereas we were merging them as a spectrum, because individuals who have reading disorders usually have some math and some written expression problems. And we wanted to have a spectrum where you'd identify the level of impairment in each of those areas to really fully characterize the individual. In the same way as with autism spectrum, you would characterize the level of impairment in social communication and restricted repetitive, behaviors and interests. But some of these people tried to do an end run and try to bring pressure. So the nice thing is we were effectively able to blunt that. And we'd tell them what we were doing, and we didn't do what the congressman wanted us to do. Now, however, I really worry about my colleagues in the WHO who, instead of having one Congress to deal with, have 193 countries to deal with, all of whom can bring pressure to bear on what the World Health Assembly says is going to be the final criteria for the ICD-11. Whether or not that kind of mischief is going to take place is one that I am going to be watching from a distance. I won't be in the mix for that. But mental disorders do have a certain, social and political resonance, if you will, and it is something that you have to pay attention to. But I think that there's a real advantage to the medical community kind of policing itself, and not having, you know, the state legislatures or the national legislatures trying to tell, you know, doctors, you know, how to practice their art, because I think they're going to get it wrong if they do so. So.
Okay, I think we should close. Thank you for both eminent speakers. Thank you for AstraZeneca for organizing this activity. For our colleagues, we are coming to the close of this closing of this session, and I feel unfortunate that we didn't have many of our colleagues in the government and private sector to attend this actually interesting activity done by Professor Darren and Professor Adam. They have a flight at 7 p.m. Today to Riyadh, and another activity tomorrow in Riyadh with our colleague. We hope that the best luck for them with our colleagues in Riyadh city, and they enjoy their short stay with us in Saudi Arabia. Hopefully to see them and meet them here, or maybe we'll see them in the States in one of the ABA conferences, inshallah, in the near future. Thank you, everybody.
Thank you. Thank you for your hospitality, and it's very interesting to hear from you. And if anybody has any other questions, you know, by all means, we'll be here for.
I'm very glad to meet you. My pleasure. Thank you.